Hello, I'm Dr. Steve Karstensen, Chief Dental Editor of Dental Sleep Practice, a MedMark publication. Welcome to an informational discussion and Q&A with Dr. Krishna Sundar. In our webinar today, we'll be discussing the history and the future of the Apnea-Hypopnea Index as it relates to obstructive sleep apnea metrics. Before we get started, I'd like to invite viewers to use the Q&A to ask any questions. They'll be answered at the end of the session as time permits. Now, I'm pleased to introduce our speaker. Dr. Krishna Sundar is currently the medical director of the Sleep-Wake Center, University of Utah. He's American board certified in sleep medicine, pulmonary disease, critical care medicine, and internal medicine. Following his medical training in India, Dr. Sundar did his residency in internal medicine at St. Luke's Roosevelt Hospital, Columbia University in New York, followed by fellowships in pulmonary, critical care medicine, sleep medicine, and Utah. Thereafter, Dr. Sundar worked with the Utah Valley Pulmonary Group in Provo for nearly a decade, where he developed an interstitial lung disease program and directed pulmonary and critical care research for the urban south region of IHC. In 2012, he joined the University of Utah full-time and helped expand the sleep medicine program and fellowship. In addition, he's developed a multidisciplinary sleep apnea program that includes collaborative care with dentists and ENT. His team's approach is focused towards improving outcomes for chronic disease and has made key partnerships with pulmonologists, cardiologists, bariatric surgeons, and other specialties in addressing the burden of sleep disorder breathing. He also conducts research on intermittent hypoxemia, OSA-related outcomes, impact of sleep apnea on chronic lung disease, and a number of other interactions between sleep and systemic disease. Currently a fellow with the American College of Chest Physicians and the American Academy of Sleep Medicine. Very qualified speaker for us today. I'm very curious about this topic, so I'll thank you so much for joining us, Dr. Sundar. I'd like to turn the webinar over to you to learn more about today's topic.
I want to say, Dr. Karstensen, thank you for that introduction. I would also like to thank SomnoMed for the invitation to discuss this topic, which is quite an important one for all practitioners dealing with this highly prevalent disorder.
Absolutely. I'm so glad you're here. So can you tell us about the AHI, the history behind it and why we use that?
So, yeah, gladly. So like every concept in medicine, the concept of AHI also evolved in a stepwise manner. And this started in the 60s and 70s when we started measuring airflow in sleep. But a lot of the credit for getting the medical community to recognize the need for quantifying breathing abnormalities during sleep goes to Drs. Gimeno and Dement. So they had a number of key publications around apneas in the late 70s, and they proposed a definition of apnea as cessation of breathing for 10 seconds or more. And it's interesting that this definition of apnea, or this duration of airflow change, has remained ever since. So later, Dr. Gimeno proposed the concept of apnea index as the number of apneas per hour, which caught on, and for a considerable period of time, both the total number of apneas during sleep and apnea index was cited in studies. So the concept of hypopneas evolved in the 80s, and by the late 80s, Apnea-Hypopnea Index was increasingly used, although the issue of hypopneas continued to remain controversial. In fact, in the first edition of the International Classification of Sleep Disorders in 1990, there is no mention of AHI or apnea index, and sleep apnea is categorized purely based on symptoms. So it was a landmark study by Terry Young and colleagues from the University of Wisconsin. And this study looked at the prevalence of elevated AHI in middle-aged Wisconsin state employees. And this is where the thresholds for abnormal apnea-hypopnea indices became entrenched, of more than 5 per hour, and for moderate sleep apnea for more than 15 per hour. And this is what we have continued to use. And in this study, using an AHI threshold of more than 5 per hour, the prevalence of sleep apnea was in 24% of men and in 9% of women. And when we categorize based on an AHI of 15 per hour or an AHI of 5 per hour plus sleep apnea, sleepiness, and this is what they termed as sleep apnea syndrome, They found a prevalence of sleep apnea in 4% of men and 2% of women. And this prevalence has been quoted for a long time. So in the mid-90s, it became quite clear that the majority of events that occurred during sleep were hypopneas, and there was increasing inquiry into the best way of qualifying hypopneas. And with this inquiry, there were also improvements in technology for measuring airflow, particularly the addition of nasal cannula pressure transducers. And these are more sensitive for picking up hypopneas, and this is what we continue to use till date. So moving forward, what has happened in the last 2 decades? So from 1999 till the middle of last decade, there have been a lot of publications about what is the best way to categorize a hypopnea. And this table shows all the different definitions over these years. And currently we use 2 different definitions for hypopnea. One that's through the American Academy of Sleep Medicine, and the second what the Medicaid criteria is what is also followed by a number of other insurances. So the ASM definition of hypopnea includes 30% or more reduction in airflow with either a 3% or more oxygen desaturation, or this could also include a 30% reduction in airflow associated with arousal from sleep. The CMS definition uses a 30% or more drop in airflow with an oxygen desaturation of 4% or more. And as I mentioned before, it's important to get this definition right, as majority of the respiratory events are hypopneas. And the ASM has done considerable work in getting consensus on scoring of these events. And this is a seminal publication that came out in 2007, which established norms for recognition and scoring of respiratory events. So over the years, technology has evolved, and there was change to RIP bells for measuring respiratory effort. And of course, there was explosion of home sleep apnea testing. But through all these, AHI remained the main measure for categorizing sleep apnea. So where are we right now? So coming to the present, the current definition of the severity of sleep apnea was proposed in 2005 in the second iteration of the International Classification of Sleep Disorders. And this has been continued in the most recent version of the ICSD in 2014. And AHI, to some credit, has delivered in our ability to recognize airflow changes. And using AHI definitions that were shown before, we have realized that airflow changes are very common during sleep. So using the current cutoff of more than 5 events per hour, the prevalence of sleep apnea is staggering. So this is the first aspect of AHI we have to recognize, that while it's a good starting point to categorize sleep apnea, population-based studies show a high prevalence based on this threshold for OSA diagnosis. And it occurs in almost a third of the general population. And this is not something unique to US, to the United States. And this study is, which was done in middle-aged adults in Switzerland and used polysomnography to diagnose sleep apnea. The prevalence was 23% in women and 50% in men, and it raised the question whether the AHI was too sensitive a measure to diagnose sleep apnea. So this is the first aspect about AHI. The second aspect about AHI is that this is the main measure we have used over the last few decades to look at disease associations. And this is a figure from one of our recent reviews that shows that sleep apnea, as diagnosed based on AHI criteria, is associated with disease in every organ system. And a lot of these interactions start as mere associations, but over time, there are causal implications, as has been the case with hypertension and depression. So in large studies, such as the Sleep Heart Health Study and the Mr. Oz study, a number of important associations between AHI and diseases have been made. But when we started doing randomized studies to look at and see whether how AHI reduction using CPAP would affect outcomes, and I give the example of studies that have looked at cardiovascular outcomes, which have included almost 4,000 patients. Reducing AHI by using CPAP has not shown a significant relationship with cardiovascular outcomes. And even though there have been a lot of issues with CPAP adherence in these studies, These have led to questions as to whether the AHI is reflective of the morbidity stemming from sleep apnea.
So does that mean that AHI is still important in diagnosing, or is it becoming less important? What do you see for going for the future?
So AHI is by far the most studied and accepted way of measuring the frequency of breathing abnormalities in sleep. And this would be a good time to understand what these airflow changes are that the AHI reflects. So sleep makes us prone to both obstructive and central sleep apneas. And most on the call know that the OSA occurs due to a collapsing upper airway. The other way we can have changes in breathing is due to variations in output from the respiratory rhythm generator, which is located in the medulla. And the AHI is able to get to the heart of these airflow changes, whether it's obstructive apnea or a central apnea, and therefore continues to be used for measuring these events. And these pictures show what a central apnea is and an obstructive apnea is. And as you can see in these tracings, in the central apnea, you don't see any respiratory effort in the rib channels from the rib cage and the abdomen. And these tracings also include esophageal monitor, which is a much more sensitive way of measuring respiratory effort. And I thought I would throw in this slide about our tendency to develop obstructive sleep apnea. And looking at it through the evolutionary lens, we can understand why it's so prevalent. So as you can see in this picture, humans are endowed with an uniquely long upper airway as compared to most other mammals. And even though this long airway has facilitated speech, which is the basis of the great leap forward, it has also made us more susceptible to obstructive sleep apnea. The other thing that has occurred is that there is significant crowding in the back of the pharynx because humans don't have a snout like other mammals do. And this would be of interest to our dental audience. And this is what makes us more prone to impacted wisdom teeth as compared to other species.
That's. Go ahead. Yeah.
So, and so in this picture, I show that this equalization of this distance between the incisors to the back of the throat, once it became equal to the vertical distance between the soft palate and the larynx, this is what facilitated speech, but it also gave us a long airway, which is capable of collapsing at night when the skeletal muscle lining the airway relaxes during sleep. So this is what makes us uniquely predisposed to sleep apnea. And it's almost as though all of us are prone to develop this. It's not a question of whether we'll develop sleep apnea. It's a question of when we'll develop sleep apnea.
So those event counts, like the Hypnolaw study you quoted there, where 50% of the men in that town in Switzerland have sleep apnea. The question came up was, is that something that's so natural for humans that it's not really a disease, it's just a condition? And so does that mean it's gonna change people's perception of the AHI as a way to label it, to diagnose it, to point to treatment?
Yeah, so the one thing we need to look at is what happens downstream of these airflow changes. So as I mentioned, I mean, the AHI is great for picking up airflow changes. And as I said, it may be too sensitive a measure. But these changes in airflow can occur due to a number of reasons. And unfortunately, the AHI does not help to understand the physiology of these airflow changes. And I'll come to more of this in the next slide. The second thing the AHI does not capture is downstream events. It does not tell us about the degree of oxygenation abnormalities. So in terms of the definition of hypopnea, we can qualify a hypopnea either if there is an oxygen desaturation or an arousal. And so we give equal weightage to both, and that gets counted as an hypopnea. So it does not tell us whether a hypopnea is associated with an oxygen change or sleep fragmentation. Similarly, the definition of apnea is simply a reduction in flow. It does not tell what degree of oxygenation abnormality occurred or whether an arousal occurred. And this would be a good time to go into the physiology of airflow change during obstructive sleep apnea as it's relevant to dentists and the application of mandibular advancement devices. And a lot of this work in this space has been done by the Boston Sleep Group. And this is one of the recent articles by Dr. Danny Eckert and co-authors in the Journal of Dental Sleep Medicine. And they describe what they term as different endotypes or physiologic traits that leads to apneas and hypopneas in patients with obstructive sleep apnea. Now, it's easy to understand this phenotype or endotype, and you can see that there is a marked narrowing of the airway, which predisposes the patient to sleep apnea with sleep onset. And the other way the airway is kept open at night is that there are upper airway muscle dilators, which get activated when the airway is closing. And if there is any impairment in this muscle responsiveness, and this tends to happen more with aging, there can be airway closure. And this is one of the reasons why you see such a high prevalence of sleep apnea as we get old. So the other two endotypes are a little more difficult to understand. So these are something called a low arousal threshold or an easy tendency to arouse, and something called loop gain, which looks at the amount of ventilatory change that follows a ventilatory disturbance. And both these endotypes, a low threshold and a high loop gain, can lead to something called respiratory instability. So if you're having a lot of changes in airflow, that can lead to oxygen desaturations, which can get counted as hypopneas. So the other way to look at that is to look at something called the critical closing pressure. And this is something that refers to the pressure at which the airway closes during the night. And so it's easy to understand this type of airway, which can close at higher pressures. And in these patients, there is significant anatomical narrowing. And what we need are treatments like CPAP or major targeted surgery to open up the airway. The other type is where the critical closing pressure is much lower. I mean, it takes a much lower pressure to close the airway. And in these are the patients with this high loop gain or low arousal threshold endotypes. And for these, non-anatomical interventions are typically used. So what happens in between are the ones most benefited by mandibular advancement devices. So unfortunately, the AHI does not tell us all this information, and that's another drawback of the AHI in trying to utilize this for diagnosing and qualifying the severity of sleep apnea.
So we are seeing some alternative metrics coming along, and you've mentioned oxygenation several times. So SpO2, and is that going to be the metric we're going to see going forward? Is going to be the most important thing, the intermittent hypoxemia?
So, I mean, that it's a good question. That one of the most important effects of a variation in airflow is a drop in oxygen saturation. And of these three downstream effects, the drop in oxygen saturation has become the most important downstream effect. So we have a very unique pattern of oxygenation abnormality in sleep apnea, what we call intermittent hypoxia. And this is something which is pretty unique to sleep apnea, because nothing else can cause this kind of pattern apart from changes in airflow. You cannot have changes in circulation causing these types of fluctuation in oxygen saturations. And as you can see, once you take out these airflow changes, in this case, CPAP applied in the second half of the study, everything melts away, all these abnormalities melt away. And these are important because they can cause a number of other downstream effects. So the desaturation can lead to carotid body activation, which can lead to autonomic sympathetic activation that can lead to hypertension, besides a number of other things. The resaturation can actually lead to oxidative stress. So one can think of that as a mini ischemia reperfusion injury. And that over a period of time can lead to cumulative effects, can lead to inflammation and other pathways of damage. And this may be different in different organ systems, and that may be one of the reasons why we see so much variation in expression of disease from sleep apnea. So in order to look at this a little more closely, given that this hypoxic hypoxemia during sleep is important in causing organ dysfunction. One of the problems with AHI is that it does not tell us anything about the hypoxic burden. So we looked at the definition of hypopnea as 3% or more desaturation. It does not tell us anything about the depth of desaturation or the duration of desaturation, as you can see in this figure. And if you were to add up all these red areas and use a metric called hypoxic burden, that seems to correlate better with cardiovascular outcomes than AHI. And that's why this whole oxygenation abnormality during sleep has become quite important.
So is that going to be like the holy grail, the term that we're going to use is hypoxic burden? Is that going to give us that label that we're looking for?
Yeah, so besides changes in oxygenation, we can also see changes in carbon dioxide. The problem is our technology is not good enough to measure breath-to-breath changes in carbon dioxide. I mean, these technologies are where oximeters were in the 80s. The second thing that happens at night is all the sympathetic activation. And one way to look at that is using something called heart rate variability, which even your Apple Watch can give. But we don't know where to measure this during night. And this is something that we have to understand better. And the third thing is looking at sleep quality. So the way we have categorized sleep is based on 30-second epochs. And just quantifying sleep state changes and arousals is not good enough to understand how this airflow changes impact sleep. So there have been a number of novel metrics such as the odds ratio product and arousal intensity that have been proposed. So now we are understanding that sleep apnea is a pretty complex condition, and just the frequency of airflow changes is not good enough to qualify the full spectrum of disease. So herein we start drawing parallels to other complex diseases such as COPD, for which we use a measure called FEV1. So the FEV1 is a measure of how much breath can be exhaled in 1 second. And we have used this measure for decades for both diagnosing and categorizing the severity of COPD. But like the AHI, it does not capture the reasons as to why there is a decrease in the FEV1. And an FEV1 value does not tell us what the risk of COPD exacerbation or the degree of dyspnea is. And in the same manner, the AHI cannot tell us what the degree of sleepiness is going to be or what the likelihood of organ dysfunction is going to be. So for COPD, a couple of decades ago, they proposed something called the board index, in which they included not only the FEV1 as a measure of obstruction, they also used other indices such as the BMI, dyspnea, and exercise capacity. And we are kind of heading in the same direction with AHI. So this is from an editorial by Dr. Gozal and colleagues. And they look at a number of different parameters, not only just sleep parameters. You can see that AHI is on the top here. They include hypoxic burden. They include heart rate variability, arousal index. And they mention using this in conjunction with other risk factors such as age, body mass index, and other comorbidities to come out with a composite score that will give us a better prediction of what this AHI value means. So the other thing that's happening in this space is looking at normal airflow metrics. So now we have some really cool analytical tools that can give us some idea about the degree of ventilatory effort, the periodicity of breathing, the ventilatory drive. And with these, there are newer and newer airflow metrics that are being proposed, which can be used to correlate with outcomes. And already they are showing that they are better than AHI in looking at different cardiovascular outcomes.
Wow. So there's some different technologies. You mentioned Apple Watch, for example. That's just one of them. I have an Aura ring. I have an Apple Watch. I have, my patients ask about these things all the time. Is there some of these technologies are giving us what they're calling an AHI, or you're calculating it from different biosignals? What do you think the future is for that, given what you've just talked about some of these other terms, ventilatory burden, oxygen desaturation index, and hypoxic burden? What, how do we knit those together to get a clinical picture?
Yeah. So these are not yet ready for prime time, but what you mentioned is that there are a lot of different technologies trying to give us an AHI or a value like the AHI. So the American Academy of Sleep Medicine came up with this manuscript in which they actually gave a way of qualifying the different indices that different technologies use. And this has been very helpful in trying to understand all the different ways we are trying to qualify AHI using different technologies. So something called the watchpad that looks at the peripheral arterial tone is very well validated, and it's correlated with the AHI. So when these new technologies comes and they use these different types of algorithms and metrics, again, I think there is enough literature that's accompanying these, and this is something that practitioners will have to look to. And also the AHI as ASM as a technology portion in their website, which actually gives us some information about all these new technologies.
Yeah, I recognize one of the names there is a physician I work with in Seattle all the time. And so he sends patients over with a watchpad results frequently, using that as a good diagnostic tool. Yeah. So I guess they're trustworthy if they go through this type of evaluation and meet some of these requirements. Yeah. All right. So what about, like, if we're going to keep track of our patients chronically over time, one of the things, if they've been diagnosed with an AHI, is that something we want to make sure we keep measuring in the traditional way, so we can use that data longitudinally to see if our patients are getting better or staying the same?
Yeah, so there is the AHI values that we get from our CPAP devices are well correlated in terms of how they stack up against what is measured using polysomnography. And I think even for dental appliances, there have been ways to measure the duration of use to show how adherent patients are with these devices. So we have to look at both the adherence and the efficacy of these devices. And if there is any doubt, these patients need to be tested using home sleep studies or polysomnography to see what their AHI is using a certain intervention. So one of the things is that most of the studies, the outcome studies that we have had, is just using a single night AHI and looking at an outcome 5 or 10 years down the road and trying to take out all the confounders. And while that's something that we have used to try and understand the implications of sleep apnea, we need to start doing better analysis of multiple nights, given that the nightly burden of sleep apnea can change because of changes in position. It can change because of occurrence of new comorbidities or changes in weight. And this may be one reason why there is so much variation in outcomes between different studies. And we may need meta-analysis and bigger data to look at these outcomes better.
Well, we all work under the burden of clinical care, typical systems. You're working in a academic setting. You worked in all those other places I read about earlier. I'm in a private clinic. I teach other dentists about it. People that read the magazine want to know what's going on. And so we have these systems, and we have, overlying all of that is reimbursement systems, which, does has a large role to play in how many tests we get to run and what qualifies a patient for what kind of treatment. So that's all seemingly built on AHI. Is that how you see it as well? And how would that change that would allow us to continue to be good doctors for our patients?
Yeah. Yeah, so currently we don't have any other measure which is as validated as the AHI. And I think in some ways it captures the actual problem of closure of airway during sleep. But the problem is that we don't know how that AHI value relates to what the patient is complaining of or not complaining of. A lot of our patients are quite asymptomatic. And it's not good at predicting outcomes. That's what we need to do, is that we need to tailor whatever AHI we get for an individual and tailor it to being able to predict their risk much better. And then because we don't know that, we still do not have good answers to which patient will benefit the most from AHI reduction. And then we also don't know what is the best way to reduce the AHI, because we have a sort of a one-size-fits-all approach using CPAP for a lot of these patients.
What do you, so I think you kind of opened the door for what some of the field could do better. What could physicians do better? What could dentists do better? What could therapists do better in terms of how can we shape our therapies for an individual patient's best outcome? Is that going to be like symptom driven or symptom noted, or is it just going to be using one metric? What do you think?
Yeah, so there has been quite a bit of discussion about looking at excessive daytime sleepiness in conjunction with AHI. It's already being done in a number of studies. It's been shown to correlate with cardiovascular outcomes. But we need to understand better how sleep apnea affects each organ system. So we need to understand the pathophysiology much better. The problem is that it takes years for some of these ill effects from sleep apnea to occur. So this is not an easy thing to study. And for a lot of the patients that we see, they already have comorbidities that have occurred, which may be from their sleep apnea, and their body has a new equilibrium. So that's one problem. But I'm quite hopeful of these novel measures of airflow change that I showed in the previous slide. And they may not only tell us more about how these changes in airflow are occurring, but they may also give us some idea about which best therapies to use for these patients.
Is that what you think in the next 5 years we're going to see more and more of, is more individual patient-directed types of therapies?
Yeah, I'm quite hopeful. I think we are slowly inching towards a better understanding of how sleep apnea affects the body. I mean, we have learned a lot in the last few decades about breathing disruptions in sleep. I mean, breathing is the most important function of the brain. And this is probably one of the breathing disruptions are the main reasons why sleep gets disrupted. And it's not only the sleep disruption, it has a lot of other systemic effects in terms of the occurrence of chronic disease. And when we talk about chronic disease, and we are not just talking about cardiovascular disease or pulmonary disease. I mean, we're talking about glaucoma, we're talking about renal failure, we're talking about non-alcoholic steatohepatitis. So I think we'll see better use of these airflow markers that I showed. AI is coming. It's able to correlate these airflow signals with a number of other signals, especially the EEG. That'll give us a better information. We have better longitudinal data, especially with EMRs. So I think all of that will help us correlate the importance of not only AHI, but multiple other things like hypoxic burden, autonomic activation, the EEG disruptions in sleep, and look at outcomes much better.
Yeah, it's sometimes hard for the system. It's hard for the system. It's hard for individual doctors to give up what they've known for a long time, what they've used for a long time, and move on and think of something else to pay attention to. But that's a challenge in every profession. And so as we go forward with this, then ASM and folks like you and folks like I love the work of Danny Eckert. moving us forward to thinking bigger picture. Well, actually, bigger picture and also individual, which kind of is, I guess, contradictory, but we have to look at that. What's the research showing? What clinical expertise is showing us in, and how do we apply it to that individual in the chair?
Yeah, no, I think that's well put, is that we need to understand the bigger picture of how these airflow changes occur, and we need to personalize that to the individual. And I think it'll take time, but we are probably headed in the right direction.
Okay. You know, a question came in that I could have asked this question is, we have a patient and a physician does a diagnosis, sends it over to me, the dentist, or the questioner, and we give them an oral appliance, and man, they feel much better. Their sleepiness is gone. Their snoring is now no longer a problem for their bed partner. They go back for follow-up testing, and the AHI hasn't budged or hasn't gotten low enough.
Yeah.
What do we do there?
Yeah, and that's something that we see quite often.
Yeah.
And again, we have to take that aspect of the patient feeling better into consideration. And we also have to see what are the other ways we can try to improve AHI. I mean, not all these patients need a CPAP. I mean, there are other ways of improving AHI, and sleep position, weight reduction. So there are quite a few other things. We need to continue to work on that. Unfortunately, that's the only objective measure that we have to understand what's going on in terms of airflow changes at night. But that does not mean that what you have done in terms of advancing the mandible is not helping. So that's something that we need to understand better. And that's where we need better markers to understand what's going on.
So the thinkers in the profession are going, okay, I'm staying curious about what else to pay attention to.
Yep.
Yeah. So, all right. So this question comes in, and you know, I know you're not speaking for every physician out here, but physician, you know, depending on the one marker we have, the AHI, they get to the definition of the disease, and you know, at 5.1 means they have obstructive sleep apnea. How does can you speak to how physicians decide on what therapy is the right course for patients of real mild sleep apnea? That I know in my clinic, I see the 5.1s. That's what the questioner said here too, is, you know, when they barely qualify as defined for the disease, but yet they're given the same treatment as somebody who has, you know, one is 10 times as the numbers.
Yeah. So I think the patient is important here. So, and we may have patients with AHI of 3 or 4 who are quite symptomatic. And just because one sleep study shows that they do not have sleep apnea, it does not exclude the fact that they cannot have sleep apnea when measured on repeat studies. So one is that. So it's the main thing is that we need to understand AHI in the context of the patient, and that's what one of the problems I mentioned is that you have a patient with an AHI of 5 who's very symptomatic, and at the same time you have a patient who has an AHI of 50 or 60 who's driving a truck and does not have any symptoms of sleep apnea. And that's where the AHI is not able to predict either the symptom or even any of the long-term outcome. So we really need to look at the patient and not just a single number, which may or may not be reflective of the disease burden from occurring from the AHI. Does that answer the question? It's not an easy question to answer. I mean, I think the biggest value sometimes for AHI is to help them get a specific therapy because a lot of this is quite restricted because of insurance and other reasons.
Yeah. That's certainly one of the limiting factors is, you know, who's going to pay for it? Because you mentioned your highly symptomatic patient with a one night sleep test that unfortunately shows the AHI 3 or 4. And you as a physician and even me as a dentist could look at that result, talk to that patient, realize, well, that probably wasn't accurate, but insurance company limitations might, say, well, fine, treat you if you want, but we're not going to pay for it. And that's unfortunate for our healthcare system, and neither you nor I are spokespeople for that system. But I can tell you that your answers, from a clinician standpoint in my community, I'd be happy to have you on my physician team, because I can tell that you're one of the breed of physicians, and we have them everywhere, that look for ways to meet the patient where they are, and that's really so important. Yeah.
Thank you.
Yeah. So I know, because I know our sponsors, SomnoMed, are pretty well, and they're really doing a lot to find doctors like you and dentists that are interested in working with doctors like you, because it really is about the patient. And something else you mentioned that we're all excited about, but nobody knows when it's going to happen, is how can we use an oral appliance like CPAPs are? How can we get data about utilization? How can we get data about effectiveness of treatment through oral appliances? That's a long-standing frustration for physicians, because you guys are used to the data you can get off of CPAPs. Well, that's coming someday for oral appliances. Yeah.
No, I think it's that collaboration is critical. We collaborate with 2 dentists, and one of the, I think you mentioned that it's very important that after getting the dental appliance, they need to have a sleep study to see what exactly the benefit has been. And unfortunately, it's back to AHI, but that's all we have. And we do see quite a number of patients that have benefited both in terms of symptoms and AHI. So that's also good to know. It's always that the symptoms have changed and the AHI is still stuck as where it is. So
doesn't mean that either treatment is bad, and then that's kind of one of the messages there. Just because the AHI doesn't go down, if the patient's better, they're better, and we keep looking, but we don't have to automatically assume that any treatment, whether it's CPAP or oral appliance or whatever it is not improving the patient. Yeah. Okay. So, well, that's all the questions that have come in so far. If you have another question, please email us and we'll get that in front of you. And I urge all of the dentists that are watching this to find doctors like Dr. Sundar in your community, because it's when the collaboration works together is when our patients get better. And SomnoMed, I know, is working hard to find dentists and physician collaborative partners in many areas. And that's a very big positive for our community health. You saw the statistics that Dr. Sundar shared, that half of our population has a breathing problem, plus or minus. There's a whole bunch of folks out there. So we need all the Dr. Sundars we can get. We need all of the dentists that we can get. We need all the companies that are working hard to make it happen, like SomnoMed. So I really appreciate the sponsorship of this really stimulating conversation. So take this information to your local sleep physician and have that conversation about what AHI and what does the sleep doctor that you're working with think about? What is the metric that they want to use? How can you work together like Dr. Sundar does with his dentists and pulmonologists and all the other specialists there? Because it's not just one of us that can help this community health. So I appreciate all of this. I really appreciate your time, Dr. Sundar, to put this together and to share your time with us and our sponsor, SomnoMed. Thank you very much.
Thank you. No, I really enjoyed this.
Yeah. Let's all go out there and do our best and help our community health get better and better and better.
Yep. Thank you.
Thank you.